I'm Kim. I'm from Claro, and we have Amanda in the room. And we are just here. We just talked with the ED physician, Dr. Dick, and we talked about ED setting the stage for that medical necessity and the patient's status, and their documentation is very important, and we definitely use it as we look at the records and as the providers decide on the status. They definitely communicate to them. So now we'll talk about the attendings, the documentation and reflecting that accurate picture for that patient acuity and that disposition status. So it's some documentation concepts that we will review for them, okay? So our learning objectives for this presentation is the role of the attending provider. We'll also talk about the ED provider's communication with the provider and UR and case management in what they're seeing, the presentation of the patient. But we definitely are going to talk a lot more about their clinical thought, thinking in ink, and getting your thoughts on the paper. We can't make assumptions. Even Dr. Dick brought up about, well, can't you make inferences of when I just clinically describe the patient? Like, no, we definitely need that description, but we definitely need a diagnosis to correspond to that clinical description. So accurate, complete documentation of the why and that medical necessity we'll review. And the patient's disposition, what are the key areas that we're seeing to support that medical necessity, and some of the CMS guidelines about it, and then those key documentation concepts that we just see across the continuum, even in, of getting that information about that patient, that accurate story about the patient with the documentation language, what can be captured by the coders. We know that there's sometimes a gap in clinical thought, and then what we can capture in coding. It is a gap, and that's why we have CDI to help fill that gap, and coders help fill that gap. Uncertain and unconfirmed conditions, documentation specificity, how important that is in that patient status. So this is totally about patient status, but we know that the documentation supports the accurate patient status. Okay? So the goal is accurately and completely representing the complexity and severity of the patient's clinical picture. We don't talk about money, even though that does fall out. We feel that when it's accurate, you will definitely have the reimbursement, your profiles will be right, but it's about an accurate, complete representation of that patient. And determining the correct status for that patient is part of that story. So if it's an observation or an inpatient status, how do we support where that patient goes? And we want to get it right from the very beginning. So patient status, we have patient disposition options or status options. We have 4 basic ones. So we treat and release. So we're going to treat them in ED, and the ED doc says, okay, they can go home. Outpatient in a bed. Maybe ED has treated, but we're waiting on that one piece of lab, and then they can go home. They should not be observation at that time. It's not that patient's fault that we can't bring in the MRI person is not available, and we just need that MRI done, and then they can go home. That's not observation. That's just waiting on that one test, and then they can go home. That doesn't meet that goal for observation, because observation has some set criteria too. Observation status, we have set standards for that. And then if the patient should be an inpatient admission. So the initial patient disposition and decision is solely based on those clinical needs of the patient. And then it will be that provider to determine that. It's not going to be interqual. Is that you? Say, hey. Okay. So can you change it? So observation versus inpatient. So we have that 2 midnight rule. I'm sure the physicians are very familiar with this. The 2 midnight rule provides the following requirements: an inpatient order from the provider, documentation of greater than a 2 midnight stay, and then that medical necessity. So it's not just the length of stay, it's building that story that it's medically necessary for that patient to stay. And sometimes we're missing that piece of the physician's medical decision of the why, the risk involved of something adverse occurring for that patient. What are they considering the presentation of that patient? So CMS is very clear that the determination of that status can only be made by the provider that is caring for the patient and knows the patient's history and the risk factors. So it's not because case management told me to do this, or you are told me to admit them to inpatient or observation. It's the provider's decision. So there are 2 additional terms used in the guidelines around that 2 midnight rule. If the patient stays greater than 2 midnights, it's presumed that they probably should be inpatient. So they have a presumption that this would be an inpatient admission because observation really should take place 24 to 48 hours, really 36, that, you're observing that patient, and after that, then why are they still here? Are they inpatient? Is something going on that they should be inpatient? And then a benchmark. If the patient's changed from observation to inpatient and then discharge resulting in less than a 2 midnight, the CMS considers all of that stay, stay, even if they've transferred from another hospital, they consider all of that stay within that 2 midnight. So that should be considered. How long have we been having to take care of this patient right now, even in an observation status? So it's a benchmark there of that care. How long is the patient receiving care prior to that change in status to inpatient? Okay. So the physician is in a unique position to incorporate all of that evidence in that medical record to detail why that patient will span 2 midnights, and then their expectation that they will expand 2 midnights and the medical decisions, their history, et cetera. So we definitely need all of that in the medical record. It's not just a 2 midnight rule that we're going under. It's medical necessity, too. It's a medically necessary stay. Here's some examples of physician's documentation. No, that's the next one, Amanda. Okay, yeah, the patient needs acute inpatient care for 2 midnights because the source of his fever is unknown at this time. Based on his continuing decline, I am concerned that he may suffer septic complications resulting in further decompensation and require additional monitoring to ensure the medical condition, safety, and health are not at risk. We will continue the IV antibiotics. So we need all of that. We need that, your thoughts. So I know it's a little bit of an extra step, but one time of saying your decision is important in supporting that medical decision to be an inpatient. So this is a CMS rule. The decision to admit the beneficiary should be based on the cumulative time. Again, we say it's the whole time the patient has been cared for, even in the ED, OBS time, it should be considered. So I just want to say that their rule. Here's a matrix. If you're thinking greater than a 2 midnight rule, then 2 midnight, then you should probably consider inpatient. That it's going to take more than 2 midnights to take care of this patient. But again, we still need that medical necessity met too, and we need that documented. If you are uncertain that it will extend 2 midnights, maybe start with OBS, and then after that, midnight is up, consider inpatient, that you're still monitoring, but you still need to say, okay, the goals have not been met in observation. I'm concerned still. The patient's still in severe pain or whatever you want to document of why they're needing that inpatient stay. If the patient's, again, if their observation for the first midnight, admit the patient if the second midnight is medically necessary. And if the patient is on observation after the second midnight, admit the patient to inpatient if they continue to meet that medical necessary criteria. So, but we have looked at some records, and we have 176-hour stays, many long stays, and it was opportunity to maybe be a different status, inpatient status. So we're going to look at these patients now at 36 hours and see if it's opportunity. And we've even looked at some patients that may have not even stayed. They may be inpatient. They stay less than 2 midnights. There may be opportunity. So we will look for opportunity for documentation missing from the record and to support. So you may get queries of asking you for that information to be documented, like that example that we gave you for that good example of inpatient documentation to support medical necessity.
And that documentation does not have to be done prior to discharge. We always have to get the order prior to discharge.
Yeah.
That documentation piece can be an addendum. It needs to be done timely, but it's
It's
not
even
like
worse
the
if it's
other
an addendum, then you have to go back through the chart and read again. It sucks up so much time in patients.
Yeah.
And so we're going to try to be, that's why CDI is kind of concurrent, so we're going to try to do it in a more timely manner instead of before the patient goes home. So they're going to work very hard to get it in the record, get you before the patient goes anywhere, that you don't have to add an addendum, because it is very hard to go back. And that's a dissatisfier with physicians is asking after. So we want to do it concurrently. That's the goal of CDI. So 2 midnight impact on status. With an inpatient admission, the expectation of 2 midnight is presumed. If they're going to stay longer than 2, it's presumed. But it's in special circumstances. You didn't know the patient was going to die before, the 2 midnight stay, or the patient's going to be transferred to hospice, but they met inpatient. But, the patient family decided they're going to make them comfort care. So, but this information needs to be discussed still. The patient left AMA. He met inpatient because yada, yada. I felt he was an inpatient stay, his medical risk, all of that information needs to be there, but he left AMA. Or he clinically improved before that 2 midnight. He really rallied and he got better before that 2 midnight stay, but it was still concern there. So you need to state that. When they don't meet their inpatient, they don't meet their 2 midnight stay, and they go home before that 2 midnight, you need to explain why. Because it will be pulled by Medicare to say, were they in the right status or not?
Unexpected rapid
improvement. Yeah, exactly. Unexpected rapid improvement. Exactly. So, observation status. Sometimes we just feel sometimes observation is the dumping ground to they're not meeting inpatient, we're just going to put them in ops. Well, no, some of those observations should have gone home because we do have criteria that meet that observation status is required. So appropriate for patients who require acute hospital services to evaluate and monitor and treat clinical conditions. It's a short stay. It's a reassessment, and you're trying to make a decision if they're going to be inpatient. Those that you've already made a determination in the ED that they're not going to stay, and you're waiting on that one last piece of information, keep them in ED in that status and wait for that piece, that MRI, that test, and then discharge them home. Because we find that.
We don't get very many MRIs.
Exactly. So observation may not be the status.
We talked about that. That's an opportunity area for us, just so you know.
Thank you.
Yeah.
Okay. So the why for observation needs to be there too. Why there is medical necessity for that service. Why is that patient being placed in observation? And the length of stay. You're expecting
has joined the meeting.
Yeah, so you're expecting less than 2 midnights for that patient, so that why
has left
for
the
that
meeting.
There's somebody just joining the meeting. Patients who meet inpatient criteria should not be placed in observation, so they're not in the wrong status. And patients who have need for acute hospital services should never be placed in observation. No need for inpatient services should not be in observation. So observation is not the dumping ground for those patients. Inpatient admission, that physician certification has to be there to support that. So the why, so we need that order, we need the why, your medical decision making based on the patient's history, risk, and why you feel that that patient needs that services. And then the medical necessity there, the 2 midnight. So physician certification, this has to be done before the patient goes home. The order needs to be co-signed if it's a verbal order, or, you know, if it's a written, then we need that admit order because that's when that inpatient admission starts. Must be signed and dated prior to discharge by a licensed practitioner with admitting privileges, okay? So reasons for inpatient medical services, the why, the patient needs to be admitted, and then why you're doing all these tests, you know, the diagnostic tests to support. Now, this is no magic sheet for that certification. Medicare says, no, you don't need to have a certain sheet for that. It can be included in any of your medical record, physician notes, admitting diagnoses, orders. It just needs to be there. You know, nursing assessments, what are they doing, you know, in assessing that patient? How often are they going in? Doesn't meet they don't go back and look at the patient for 12 hours. Maybe they weren't that acutely ill. You know, they're only doing vital signs every 12 hours or whatever, you know. That doesn't sometimes buy the bed. And Medicare, when they're looking at these records, they look at all of those services being delivered. So what are you doing?
What about our end, the delivering of services? If we have consultants that are overloaded and don't see the patient until maybe they're on observation, they don't see the patient until 4 or 5 that first day that they're admitted, is that taken into account as far as inpatient versus observation? Because that happens frequently, and we're stuck because I'm not going to discharge a patient until I have whatever I'm waiting for back.
So we're waiting for, keep in mind, medically necessary reasons to stay over again, and it is a fine line because CMS doesn't really, I don't mean to say they don't care if our internal processes are broken, but they look at whether or not it's realistic and reasonable. So from the time of consult, we could go back to our medical staff bylaws, say we have 24 hours to see a consult, and there's arguments that we could make as far as what would be a reasonable time frame for a turnaround time from the time you order a consult until that consult is obtained. Would you agree with that, Kim?
That's
for sure.
Yeah.
Because
so then it goes back to that medically necessary and how imperative was that consult to, is it really going to modify your plan of care and your,
Frequently it's a reason for admission, and then we don't end up getting the consult until the following day, late, or whatever.
Exactly. For instance, GI bleeds, they did a prepayment program thing for Medicare, and they looked at GI bleeds, and they felt that those were medically unnecessary. They were going to be inpatient because they felt that GI bleeds, if you get a GI consult and they find out where that bleed is, they fix it, and the patient can be in observation for a little bit and go home.
Except for they're supposed to be on a PPI for 48 hours.
Yeah, then you argue standard of care and medical.
So you have to put that medical necessity of the why.
Yeah.
What happened with this patient? This patient has risk because I need to give PPI for this length of time. So you have to explain the why. Just the GI bleed does not, but clinically we feel that GI bleed, that's a sick patient. I don't want him to bleed to death, but you have to explain the why because they will look at those cases and say, if it's not there, then this may not be medically necessary to be an inpatient. They looked at TIAs, syncopes, medical bags. These were some of those DRGs that they looked at that were inpatient that should not have been maybe inpatient, but probably they could have been if we had had the documentation to support the why.
So, sorry, just a quick question. I know you're going over it when I walked in, but like people that qualify for inpatient based on diagnosis initially, but then don't stay the 48 hours, they don't stay the 2 nights. You just, like, DKA is like a classic one. Like, you can turn them around, but they sometimes come to the ICU, but they're only there for 36 hours. So,
but you have to explain that they got better, that, you know, they
faster than you anticipated. So they responded to treatment
But they had, and because at the beginning you're going to explain their risk and the why.
Yeah.
And then when they don't stay, you're going to say the why of why they did this. So the documentation clinical indicators which support the why, these are some of them. The severity of the patient's presenting symptoms. So we want to have that in your why. The abnormal diagnostic studies that you're looking at, your thoughts of what you're seeing, his liver enzyme, maybe he's a shocky liver, he had a hypotensive episode, he's an AKI, so underlying chronic comorbid conditions and how they're interacting and with that presenting complaint and your concern for those and how that may impact.
And do we need to mention those in our text, or if we auto-pull labs in? That's documentation, right?
Just pulling the lab in is not. It is in your plan and assessment, you need to discuss it, of what you're going to do with it, okay? So just pulling them in because coders cannot make inferences. So they cannot pick up what you're thinking from that lab. So if you just put K as, 5 or 6, we can't code that as hyperkalemia.
And with diagnostic tests.
Yeah, diagnostic tests, if you're finding things on diagnostic tests, that's not a treating physician. So we will not code out of that diagnostic test. So they saw a CDA on the MRI, that CDA would not be captured until you said that is a CDA. I feel this patient has a CDA because.
Well, the problem with the CDA is we need the documentation of the effects it has on the patient, because if the patient just has minor deficits with the CDA, we've got denials on those because the patient didn't have enough symptomology.
But I think we should standardly get neurology consults on CDAs. Do we? Well, we try to.
Yeah.
Yes.
The availability of that.
Yeah.
You're able to pull from their notes, correct?
Yeah, of course. Oh, yes.
Yeah.
Okay.
But they still, it's that documentation that
Your concern.
around quicker, we anticipated this was going to be more deficits than it was.
We had
Just read it
Some
in our
additional.
exam, you have to write down their deficits in your assessment and plans, and then it'll get.
Because we've seen some, we look at it and go, clearly it's CVA. It was on imaging neurology, said it was a CVA, but there were not enough deficits. And CMS came back and argued with us and said, yeah, but they went home in less than 2 days. And they didn't even need outpatient therapy.
So that's where that physician's judgment and his medical decision of his risk and adverse.
It was that documentation that was missing.
Yeah, and that's what's missing. And because when it's taken to the ALJ levels, that's when it will be turned around in the favor of the physician if the provider has said his thoughts of his concerns, okay? So, so underlying chronic conditions, treatment, why are you ordering the test? What are your thoughts behind ordering the test? Sometimes we don't know, like, I don't know why he's ordering serial, tests like that. Medical predictability of that clinical course and that potential risk and adverse events occurring for that patient. So that CDA patient, well, we want to monitor them. And the age of this patient and their presentation, we need to monitor their neural status closer, et cetera. So those are some of the things. So those documentation concepts, and this is just documentation concepts that support that medical necessity that help us clarify the record with conditions, those conditions, that principal diagnosis if they're going to be inpatient, and these are some of those. So these support the medical necessity of that patient's status determination. It reduces denial. So we know that physician charges can be denied if an inpatient admission is denied due to lack of medical necessity. So all of your subsequent visits and that admission can be denied if that inpatient admission is not supported. It reduces those requirements for that peer-to-peer discussion for those health plans, sending those clinicals in, and they keep saying, no, he doesn't need inpatient, because it's a lack of the documentation. They're not seeing the picture, and they're only going by what's on those papers, and they're not seeing what you're seeing. Like, this patient's sick. Accurate quality measures and rankings for your physician profiling. So the patient has a bad adverse event, and we didn't have that predictability of that patient having that because we're in the wrong bucket, we're in the wrong status, we're in the wrong principal diagnosis because we have lack of documentation. Usually it's the lack of documentation that inaccurately portrays our physicians and our hospital in their profiles. So here's just a little scenario of that documentation gap. We know that patient really sick, really sick, and we're like, he's so sick, but we don't have that documentation. It doesn't meet that medical necessity to be an inpatient. And then we have a resulting of that inappropriate DRG, even if we make them inpatient. If you don't have that documentation, we still can't support it because we're going to just send out that one piece of paper, and that's what's going to tell the story. Low severity of illness, low expected mortality. That patient dies of a broken arm, but it was something else that occurred, you know, that we were concerned about. Maybe they had a malignancy. So documentation languages. We know that you describe the patient clinically. You don't know those coding terms. We don't want you to be a coder. But we know there's a gap that we have to fill. There's a disconnect of that language. Definitely disconnect sometimes. And so that's why we have clinical documentation programs. Across the nation, these are done. So, we have to fill that gap to show that clinical complexity and quality of care, those outcomes of that patient. We know that when it's not shown accurately, it's the documentation. We can look at data and see the opportunity in hospitals that they don't have a documentation program or their documentation program is not doing the right job. So we can look at the data and what that says. So these are our key documentation concepts. Clinical versus coding language, we know that gap, and that suspect, probable, likely, concern for, using those terms on the inpatient side. Even in the ED, we talk with the ED physician, in their differential, we know that they are billing they are very concerned about their pro-fee billing, and they can only bill for, in the outpatient setting, those certain conditions. If it's abdominal pain, they can't guess and bill for a suspected appendicitis. They have to say abdominal pain. That's what that would go on their bill. But they can put in their differential that suspect, likely, probable. That helps their evaluation and management, higher level of care because they're suspecting something and they're going to have to work up this patient for more. And then the specificity, that's important in those conditions. So we work in clinical documentation to make sure that these concepts are used in the inpatient setting. So suspect, probable, likely, concern for, these are used, and again, used for your evaluation and management, pro-fee billing, but also to support in the inpatient setting maybe a condition that is uncertain and it hasn't been ruled out, but based on how you treated the patient and how he responded to treatment, it's likely, probable, suspected, and we code it as though it existed. If it's still at discharge, suspected. For instance, for pneumonia, simple pneumonia, the patients came from a nursing home, they have failed outpatient treatment for a simple pneumonia that they thought they had before, but we can't get a sputum sample. We're getting spit, For most patients, we get spit. And we're not certain that this is a gram-negative pneumonia, but they failed the first-line antibiotics. We're now starting them on vancomycin. Why are we choosing vancomycin? Because we think it's a healthcare-acquired pneumonia. HCAPs only are reported as simple pneumonias in the coding language. They do not go to a complex pneumonia. So we're still going to have a simple pneumonia. This gram-negative pneumonia that we're probably treating, this patient doesn't do good because he's 90 years old and he has a gram-negative pneumonia, they died. They died of simple pneumonia. But if we had said likely, probable, suspect that this is a gram-negative, patient gets better or even they die, we had a complex, we reported as a complex pneumonia. We're not saying we're not supporting it. They came from nursing home or they had, they were in dialysis, they had contact with healthcare providers. We had the support, and now they failed outpatient treatment, we're starting them on vancomycin, and this is why we're choosing that. We're saying it's the HCAP. That's why. But we're still uncertain because we don't have sputum samples. So you still can use those terms in many ways. Outpatient setting, it cannot be coded. Inpatient, it can. For specificity, we can still use that likely, suspect. So in the etiology of signs and symptoms, what does that chest pain due to? We have ruled out that it's cardiac related. Is it likely a GERD? I'm going to start you on PPI. You're doing better. You haven't had any more chest pain. Yeah, it was likely GERD. We're going to send you home on some Prilosec, okay? Acuity, this is likely acute systolic heart failure. I don't have an echo, but based on, your how you present and your history, this is maybe a systolic heart failure for this patient. And cause and effect. The patients had a heart cath recently, and now they have AKI. Maybe it's due to, the dye that they gave. Maybe this is an AKI due to that dye, and it's the ATN. And then the manifestations, we definitely see those. Acute respiratory failure. We often see that sometimes that respiratory failure resolves in the emergency department, and we don't see it ever mentioned again. ED has mentioned it. They did look like they were in a respiratory failure. It was the diagnosis, and it's never mentioned in the next notes by the attending. We need that, once within respiratory failure resolved in ED, we can capture that. That's probably going to be their principal diagnosis, okay? It's going to help us show that medical necessity for that inpatient. So what occurs in the ED, we still can capture. We can code those conditions. So respiratory failure is one that I think about that we all know, and we will query the physician, like, he's not in respiratory failure. We're not saying now. We're saying he was. He came in like that. So even if it's resolved, once he had it, it's resolved, and that's the documentation you would put. He was once in respiratory failure, now it's resolved. He was once in sepsis. Maybe it's an early sepsis in the ED. They jumped right on it. They resolved, all those symptoms resolved. By the time you get to your H&P, you need to mention that. He looked like he was septic. It's resolved now. We're still going to treat it as though sepsis was there, and move on. And that's probably going to be your principal diagnosis. But if you answer the query, no, he's not in sepsis, then we have to go to maybe fever. Now he stays 10 days for fever, and he was septic. So that's how that ends up. So these are just some documentation pearls that we say. Possible, probable, use those. Every condition should be documented with a diagnosis. So when you're describing something, name that diagnosis, name that description, name the baby, name the baby. Acuity and type should be documented when possible, especially for conditions such as CHF and respiratory failure. Remember to avoid use of symbols as well as verses. Link known or suspected organisms to infections and manifestations to diseases. And then that specificity, those keys to that specificity, provide as much detail as you can. Here are some examples of the gap, just giving you an example. Clinical terminology, sometimes we see the description dyspnea, respiratory rate 32, using accessory muscles. ABGs, you gave a good description of acute respiratory failure, but it wasn't named. We can't make inferences that that is what you're describing. So we would need that name to that condition that you have just described. And that's why sometimes you get a query to clarify that record.
Definition than an inference. So like if I said sepsis seconds, or if I just said heart rate greater than 100 and respiratory rate of 30, I mean, if I'm defining something, do I have to put the term sepsis?
Yes. We have to have the diagnostic statement. We have to have the diagnostic statement because a coder nurse cannot assign that as sepsis unless you say it's sepsis.
The definition.
Well, yeah, you described it. You defined it, but we have to have you say that's what that is named.
You describe the baby, now you gotta name the baby.
You have to name the baby. We have a physician that travels with us. He was a physician. I guess he was over case management at University of San Diego. And he said, you know, you go home with it, you have a baby, you describe the baby's fingers and toes and how the baby looks, but it's one thing that the baby has to have before they leave the hospital. And some people say car seat, like, no, a name. A name, and they have to have a complete name. Sometimes we get half of a name. So we may have heart failure, but we don't have the name, the complete name, systolic, and the acuity, acute systolic heart failure. So this is that complete name. So sometimes those nurses are going to come to you and say, name the baby. Please, doctor, name the baby. Chest pain, MI ruled out, start arthrospasm. So is it angina? Is it because of their CAD? So naming what it is. We told the ED this is the documentation that's transferred in. We cannot go back into other records from other hospitals, even in a previous stay. We can't go back into an echo that they had 2 weeks ago prior to this encounter. We need you to bring in that information from those records, okay? And we told ED that's important for us, what you're looking at. So if that echo is 25% and you're looking at, you know, the systolic, you need to go back and look at it and bring it forward, because we can't say what's important in that previous visit or from that transfer hospital. We can't make that. We can't even ask you about it in a query. We can't go back and say, you know, at that previous hospital they said this and this and this. We couldn't even ask you a question about it. So it's important for you to go back and get that information and bring it forward. The role, okay, we went over the role of the emergency room, but the role of the attending is to provide those acute conditions, those comorbid conditions, diagnostic workup and treatment plan, and then those abnormal clinical indicators. And then to work with UR and case management and the CDSs on the documentation improvement, the patient status, that it's appropriate, okay? And we're almost done with this. The diagnostic story, if we have a complete diagnostic story and it's accurate, we can assign the appropriate principal diagnosis for that patient. And it really isn't the physician deciding that principal diagnosis. It's coding who's deciding that principal based on your documentation. So you can list them all that you want. If the documentation isn't clear, you may not have the clear principle. You know, and on the discharge summary where you're putting them in order, that may not be the order that it's reported in. Yeah. It's based on the documentation, how you said the patient presented. You said there was no sepsis, and we won't code that. So it's a lot of, if it's conflict in the record, the attending trumps everybody. So, you know, even though neuro is saying CDA, you're still calling the TIA, we're going to have to code the TIA. So those are some of those things that, some of that discrepancy in the diagnostic statements. Secondaries, we want to make sure that all of those secondaries are captured, and usually we find our secondaries in these body systems and clarifying those with that specificity. You don't have to be treating what conditions are clinically significant for that patient. If they meet any of these, one of these, we call these UHDDS guidelines, you can only just be clinically evaluating that patient for that condition. If they meet that clinical evaluation, then we are going to code that. We're going to report that condition because you're considering that condition. So you don't have to be giving a medication for that condition for us to report it. You're considering his CHF is at his baseline. We're not doing anything with it. We're going to continue the home med, but we need to report that CHF because you're going to consider IV fluids for that patient, how much you're going to give. You're still considering that history, okay? So we will report that, and we want to report it to the highest specificity for that condition. The acuity is chronic, and it's a systolic or diastolic, and it's CHF. So we would want that, all of that in the information. POA status is very important because we don't want to assign a hospital-acquired condition because that deems the hospital that these conditions occur after the patient's admitted. So present on admission means that they brought that baggage in. So that has to be clear. That POA status must be clear, and you may get queries about that too. Palliative care, we put this in for the attending hospitalists because often the patients are made palliative care and they decide comfort care, but they're still an inpatient. As long as they're inpatient and they die inpatient, they're going to be, they weren't expected to die inpatient. So you have to paint the picture of that patient that they were expected, maybe with other comorbid conditions such as respiratory failure, patients gasping for air. We're going to give morphine drip to make that patient comfortable. We're managing this respiratory failure. It is a condition that we can capture there, okay? So some conditions in palliative care we should report that we're still having to deal with, okay? And here's a clinical example quickly. This is a patient who came in with COPD, used oxygen at home, progressive dyspnea with increased work of breathing. They started, despite NIBs and IV steroids, they're still getting worse. Patient's creatinine is 4.8. The baseline is 1.1, but we only have renal insufficiency named. And the patient's going to be even transferred to maybe ICU for mechanical ventilation or BiPAP. Patient's hypotensive, creatinine remains above baseline despite fluids. We are consulting renal, labs pending. If this is all that we have, scenario 1 shows what we could capture from that documentation. Patient only has COPD, he has dependence on oxygen, and he has renal insufficiency. And that's what would be reported, but that is not the diagnostic story for that patient. And we would only be able to report 192, scenario 1, which is lowest severity. The risk of mortality is 0.2%. We only have 2.6 days to manage this patient, and the relative weight is our payment. We multiply that, and that will give us our payment for that patient. But with better documentation, even just improving that principal diagnosis, COPD exacerbation, we're able to move to that medium level. And then that patient had acute renal failure, that renal insufficiency is truly acute renal failure, then we're able to clarify that, and you see how that moves up. Scenario 3 is even more improved. As the patient stays and we work them up, he's not improving that renal status. Maybe this is an AKI with A10. Maybe this is an acute on chronic respiratory failure too, with that his respiratory status. And we move to the highest level for the COPD patient. That is the complete diagnostic story. That is the true diagnostic story. We had reported scenario 1, that would be an observation patient. But scenario 3 and 2 would probably be an inpatient. And when they're inpatient, we even have the diagnostic story accurate. So that's just an example of how we look. And then we have some severity progression slides that we have provided. We have even more in the appendix. But these are the low-level documentation, like hypoxia. These are descriptions. These are symptoms, respiratory distress. So often we're wanting more description and specificity of that status. Maybe this is a COPD exacerbation for that patient. If you just say COPD, we can't jump that it's an exacerbation. So we need that described. And the highest, maybe that manifestation is acute respiratory failure for that patient to even capture that manifestation. So this is a progression of respiratory status documentation. So we're done with this, and we're just saying, we don't want to take up your time is valuable and and it's precious. And so your workflow, we don't want to be interruptions to your workflow, but we want to be a helper to your workflow. And this is helping. When you get those queries, don't look at them as a nuisance. It truly is helping that gap and filling that gap. And they are helpers, the coders and case management. You are when they're coming to you with, that status determination. So this is, we're starting CDI in that observation, trying to get that status right in that documentation there for the status. You are, yeah.
Hopefully the goal is that if we're able to learn as we go, the queries and the status changes and all that stuff would lessen as we
Has
move
left
forward.
the meeting.
We may get more questions out of the gate.
Yes. So queries will go down. Thank you very much for your time, doctors, very much.